And I had the good fortune of writing the PFT chapter in the Murray and Edel textbook, just that's coming out this week. So glad to be here.
I think you'll like this one. I think you'll like this one. I think there's a lot to learn from this patient. Let's see. What we're going to do is we're going to let a couple of people see if they can analyze this, and then you can teach them how you approach it, and hopefully and then I'll ask you a couple questions, and then we can talk about the patient. I'm going to do we have volunteers to be on the lukewarm seat? Who's playing clinical problem solvers today?
I mean, if no one else volunteers.
It's going to be tough if you're driving, Groove, because you actually have to see the numbers.
I'm on my, well, okay, I'm not the one who's driving, but.
Okay. So, Lindsay, who's playing clinical problem solvers today?
It's a mystery. I have no clue. Maybe we'll find out at some point.
You know, it's a nefarious group, so.
Never know who you're gonna get. We could guess, and then it could be, we could figure out at the end if they'll share.
Well, I mean, you already have one.
We have Lindsay. Okay, is anybody willing to feel like they know anything about PFTs?
That's why I wanted to join.
Okay, well, Drew, you know, you're a good sport, so we'll start with you. If somebody decides they want to be brave and try to understand this. So here's the brief story. There's a gentleman older than 60 who was admitted to my service for volume overload and COPD exacerbation. He'd been admitted multiple times, and just as a routine, one of the things I do with anybody who has lung disease is I ask to see their PFTs. And so here are the PFTs. And it led me to think carefully about the patient. So these PFTs are 4 years old. So Drew, why don't you tell me how you would look at these, what thoughts you have, and then Dr. Bhatt is going to tell you how a real expert does it, and which will be better than the way I teach it on rounds.
Mm-hmm. So the first two numbers that I typically look at when it comes to PFTs are the FEV1, or the forced expiratory volume in 1 second, and the forced vital capacity, or the FVC. Oh, I think we have someone else who probably wanted to discuss, or is unmuted. So I see that we also have that this test was done with albuterol as well, and these tests are specifically done to look for albuterol responsive changes in an obstructive lung disease pattern. So basically there are two types of lung disease patterns when you look at pulmonary function tests. And okay, I should mention first that a lot of the norms for spirometry still include race, even though it's not a it's not valid, and it's a black mark of medicine's racist past. And there's been an effort to try and get rid of race in spirometry corrections. Just as an aside. But first off, so patients FEV1 is 48% of predicted, and FVC is 50% of predicted, and the FEV1 to FVC ratio is 74%. So at this, okay, so right then and there, if we are just looking at it at first glance, the FEV1 is low, FVC is low, and the FEV1 to FVC ratio is lower than 80%, which indicates possibly an obstructive pattern. And if we look at the post-albuterol measurement, it's the FEV1 to FVC ratio is down to 69%. So it's not really much of a change. So this is an albuterol non-responsive obstructive pattern.
Okay, we're gonna stop right there, Drew, because I want to go through this step by step. I know you could say a whole lot more, but Dr. Bhatt, comment on the spirometry. You've written the chapter and you're an expert. Teach us about that.
Okay, so I think an important part of this is hidden in the top. So when I look at a PFT, I first want to make sure, because as Dhruv mentioned, I think the reference equations include the age, height, sex, and race, ethnicity. Regardless of the current ongoing controversies, I think we still need to consider those. So I would certainly make sure that they're all entered correctly, if you know the patient. If not, I think at least they should be compatible with what's recorded on the EMR.
Yeah, they were, and I clipped them off for HIPAA reasons.
Yeah, I understand. I just wanted to make that comment. So whenever someone reads it, I think I do want them to look at that. And then the next thing I look at is the flow volume loops. I want to make sure they look good and are of good quality. Most times the respiratory therapist adds a comment whether the patient gave at least an observable good effort, but you certainly want to look at the curves to see some specific patterns if you can identify any. And based on this flow volume loop, I see some upward concavity in the expiratory limb of the flow volume loop, in the descending limb. So straight away, just looking at this, it makes me think a little bit about obstruction, but I don't know the normative values just looking at the flow volume loop. So I don't know if the size is big enough to rule out restriction at all. And then I look at the values. The first number I look at is the FEV1 by FVC ratio, because that's the main branch point. If the ratio is normal, and you can define normal in a couple of ways, which I'll talk about in a second. If the ratio is normal, then it could be a normal spirometry, or it could be compatible with the restrictive physiology. If it's less than normal, then that is compatible with obstruction, provided there's some supporting evidence. Now, first thing I want to mention is, the FEV1 FVC ratio has been defined as normal or abnormal in a couple of ways. And there's a huge amount of controversy right now in the respiratory community as to what's the best way to do it. The Global Obstructive Lung Disease Initiative, or the GOLD guidelines, say that you can use a fixed threshold because the denominator includes the size of the lung. It's kind of adjusted for a lot of things. So you can use a 0.70 threshold or lower to say there is evidence of airflow obstruction. Alternatively, you can use the population-derived normative values, which are adjusted for age, height, race, ethnicity, as well as sex. And then if that's less than the 5th percentile of normal, assuming that 5% of individuals are on the tail end of the bell curve and they're abnormal, you can define it based on that. So if you have access to the reference equations, there are a number of online calculators. This report does not include the lower limit of normal, but for this discussion, I think we can safely use the fixed threshold. And if you use that, general guideline is whenever you have access to a post-bronchodilator spirometry, always interpret the post-bronchodilator first. And in this case, the ratio is 0.69, which is lower than 0.70. So straight away, that makes me think of obstruction. Now I want to go look for compatible evidence to support this. So then I look at FEV1. If the ratio is normal or high, suggesting either normal or restriction, then I go look at the FVC first to see if there is any evidence of restriction. In this case, because I think the first step is compatible with obstruction. I look for FEV1, and that seems to be severely reduced at 48% predicted. So if you go by GOLD guidelines, that would be about stage 3. If you go by the American Thoracic Society guidelines, that would be severe airflow obstruction. Then I look at the FVC to see if the lung size or the surrogate for lung size is normal or not. And if it is above 80% predicted, that would have been normal. Same thing, the cutoff for FEV1% predicted is also 80%. And this is way low. And here the FVC is also low. So that makes me think that there could be one of two things going on. Either there's a concomitant restrictive process going on, or there is significant air trapping so that the effective functional vital capacity is lower than expected. So I would interpret this as severe airflow obstruction with concomitant restriction or air trapping. And then, as Drew pointed out, there is no bronchodilator response with this. So this seems to be a fixed airflow obstruction. And for bronchodilator response, you can look at FEV1 or FVC or both. If either of them increases by 200 mils and 12%, that's considered evidence of bronchodilator response. I do not use the ratio. It is not recommended to use the ratio to evaluate bronchodilator responsiveness. So I'll stop at that. And
that's really great. And we want this to be very interactive. So anything that's unclear to you, the correct thing to do is to ask questions for clarification, because we're trying to do in 1 hour what it takes pulmonary fellows quite some time to get all the nuances. I'm going to ask you a question because I've never known what to do with the FEF 25 to 75%, the FDF 50%, and the peak expiratory flow rate. And what if they don't sync up with the FEV1 to FVC? And why do we have them? Why do we even put them out there? What should I do with those?
yeah, so the FEF 25 to 75, as you know, is the slope of the 25th percentile to the 75th percentile of the descending limb. And that is thought to reflect small airways where the air is flowing through the small airways. Unfortunately, it's not panned out. And many people think it reflects small airway disease, but the range is really wide. There's a lot of variability with this measurement, primarily because it is dependent on the FVC. So if you take a smaller breath out, then the FEF 25 to 75 will be shifted leftward. If you blow out a larger amount of air, then it will be shifted rightward. So I don't think there's a good answer to this, but the variability is really high. So even the predicted equations say anything between 60 to 140% of predicted is normal. Anything lower than 60% of predicted is considered low and is compatible with airflow obstruction, provided the FVC is normal. If the FVC is low, then you do not interpret the FEF 25 to 75 because there's no saying what it really means. If the FEF 25 to 75 is higher than 140, we don't really know what that means. It could reflect increased lung elasticity, so the air is coming out real fast, but there's no real guidance on how to interpret that. We don't usually interpret that.
So because there's a low FEC, these numbers are not interpretable.
Correct.
Great. So Harsha has volunteered to look at the lung volumes and see whether or not the lung volumes shed any light into this patient.
Yes, hello, Dr. Sander. This is my very first time.
Introduce yourself. We know Drew very well, and we know that he's about to be an intern, and he's now a doctor, so we call him Dr. Drew. But I don't know you, Harsha, so tell us about yourself.
Sure. So I'm going to be an intern as well. I matched at unRemarkable Medical Center in Maryland, Annapolis. So I will be joining from 28 June, my first day. So yes. This is not my interest topic, but I get really confused with, I'm very intimidated by lung volumes and PFTs. So I'm just gonna give it a blind shot because I just want to learn. So total lung capacity, I see it's for this patient especially is low because of the reference is 6.9 and this patient is low. So the things that cause low lung capacity is mainly obstructive diseases. and sorry, restrictive because the lung is not filling up enough, and things like sarcoidosis, interstitial lung diseases. On top of my head, this is what I can think. And the residual volume is also low, but yeah, I mean, since Dr. Bhatt said that it's a mixed, it's obstructive disease with concomitant restrictive pattern, we could
Great.
say that, yeah.
Let's see what Dr. Bott has to say about these lung volumes, because I think understanding lung volumes and looking at lung volumes is underappreciated by many interns and residents, probably many non-pulmonary attendings.
Yeah, so that's a great read. So first thing to note is there is a term at the bottom that says functional residual capacity N2 or FRC N2. So that immediately tells you that this was done using nitrogen washout, which has some advantages and some limitations, which we can talk about. So just going by these numbers, total lung capacity is low. Anything less than 80% is low. And that is the only number you need to make a diagnosis of restriction. If it's less than 80% predicted, that's compatible with restriction. If it's more than 120% predicted, and 80 to 120 is being the normal range, if it's more than 120% predicted, that's compatible with hyperinflation, as you would see with severe airflow obstruction. RV, or residual volume, it's a little more variable. It's harder to measure. So the variability is high. The range is 60 to 140% predicted. So if it's less than 60%, that's low. So here in this case, it's low, and it supports a diagnosis of restriction just based on the lung volumes. Now, if you had an isolated RV reduction with TLC being normal, then that's a little harder to interpret. It could be compatible with early restriction, or it could be due to body habitus. Sometimes with obesity, you see that the RV is low, but the TLC can be normal. And sometimes we also look at the RV by TLC ratio. Now, there's no great prediction equations for this, but as a rule of thumb, I usually say if it's 10 units greater than expected, then that is compatible with air trapping, because your residual volume reflects trapped air and total lung capacity is the size of your lungs. So if that number is about 10 units greater, then it is suggestive of air trapping. So in this case, I think it is compatible with restriction and confirms what we saw on the spirometry, that there is some obstruction on spirometry, and there was possible concomitant air trapping or restriction, and the lung volume seemed to suggest restriction. The caveat to this is, in cases with severe airflow obstruction, we don't know what the structural lung disease underlying that severe airflow obstruction is. If there are airways that are not, if there are regions of the lung that are not communicating with the airways, let's say you have a big bulla in one part of the lung that's not communicating with the airways, then that can result in a low lung volume on nitrogen washout, because that's not participating in gas exchange. The only way to detect that would be to use body plethysmography, where you would use, you'd sit in a kind of a glass box and measure volume and pressure changes, and that's a little more accurate and gives a higher value for any patient's lungs, both for TLC and for RV. So this case could be compatible with restriction, but without knowing the patient's imaging and other things, this could also be to non-communicating airways.
So I'm hiding that from everybody. And the reason I'm hiding it is because I want people to listen, because this is beautiful. What you're doing is how you're approaching this and thinking of the possibilities. Then we have a CT scan, and I have other information I can give you. I'll tell you that this gentleman has been on home oxygen for quite some time. So Dhruv, do you want to see what you can do with the diffusion numbers?
So if I remember correctly, the DLCO is basically a marker of restriction if it's low. 62% of 62% are predicted. That, so I keep remembering that like low DLCO is indicative of restrictive lung disease, but at this point, I'm confused now. And
Good. So I'm glad that I finally came up with a question that Drew is really going to benefit from this explanation.
Mhm.
So this is a great thing when you ask a question and the learners don't know, because it means we need to educate better. I'm always happy when people don't know the answers to questions because that gives us an opportunity to teach. Now, DLCO, I think, is the most difficult one to understand. I don't think I understand it, and I'm dying to understand it. And I really want to know the difference between DLCO and DLCO volume adjusted when we get to that. So help me.
Okay, so DLCO is the diffusing capacity of carbon monoxide. It's not specific for restriction. It can be low. It's basically how much oxygen transfers across your blood alveolar barrier. And it's a surrogate for how oxygen transfers. So the way the test is done is the patient inhales a really low concentration of carbon monoxide admixed with oxygen. So it's about 0.03% carbon monoxide. So it's not poisonous at that concentration. And the patient takes in that mixture and holds their breath for about 10 seconds. And then they breathe out. When the air comes out, the first 750 mils or so is dead space. So from the trachea and the larger airways, so that is discarded. And after that, the carbon monoxide concentration is measured. Now, as you know, carbon monoxide transfers very quickly through the blood alveolar barrier, and it's about 10 times more, it's faster attached to hemoglobin than oxygen is. So if you have a really good oxygen transfer, then the carbon monoxide transfers even faster. So when you breathe out, you have a very low concentration of carbon monoxide coming out. On the other hand, if your barrier is impaired for any reason, which we'll talk about in a second, the amount of carbon monoxide that returns through the exhaled air is going to be high. So there are some equations to calculate how much went in and how much came out and what the proportion is, and there's some adjustment factors. So based on all that, if your carbon monoxide transfer is low, the DLCO is low, that means your blood alveolar barrier is impaired for some reason. It could be because of interstitial fibrosis and any reason that causes thickening of the interstitium, like pulmonary edema, any of those. Or it could be destruction of the alveolar septa, like emphysema, or it could be a vascular problem like pulmonary hypertension. So any of these can cause low DLCO. And commonly, you should adjust for hemoglobin if you have it available, because if your hemoglobin is low, there's not enough ligands to attach or for the carbon monoxide to bind. So your carbon DLCO can be artificially low if you're anemic. Same thing if you're a big time smoker, if your carboxyhemoglobin is say around 8 or 10%, there's not enough sites for the administered carbon monoxide to bind, so the DLCO can be artificially low. So you have to adjust for these. And the other thing is the DLCO by VA, and that is a little controversial. Generally in our lab, we don't adjust for it and we don't interpret that, although it is reported. The reason being, the one school of thought is, your effective alveolar volume needs to be adjusted for, because if you have smaller lungs or bigger lungs, your DLCO can be proportionately affected in one direction or the other. But the problem with that is if you have a lot of dead space because of disease, your effective alveolar volume will be artificially low or really low. So that can impact your DLCO by VA. So we don't really adjust for that. Although we report it, we don't really read it. It's currently not recommended to interpret that. So DLCO by itself or adjusted for hemoglobin and carboxyhemoglobin.
So I can tell you this man was not a smoker. He had a normal hemoglobin. He did have pulmonary hypertension and was on home oxygen. So let's put the story together just from the PFTs, and then I'll tell you about the chest CT and another piece of information. So do you want to try that, Harsha? This is a really complicated question, and if you don't feel comfortable, there's no problem at all, because I would say that the great majority of interns in this country cannot answer this question.
I can try, but I'm not able to see the shared screen. Is that on or is it off for everybody?
I think Lindsay disappeared. So we don't have the shared screen just yet. Oh, there's Lindsay. You got the numbers back. Thank you, Lindsay.
Sorry, I didn't realize y'all couldn't see it.
Yeah.
We need to zoom a little.
So so yeah, I can see that now. So Dr. Sander, could you repeat the question?
So we've discussed the spirometry, we've discussed the lung volumes, and we've discussed the diffusion. So what would you do next? And what are you thinking the diagnosis is?
That's a really hard question, and I don't know the answer to.
Right, I told you that I think most interns cannot answer this question. And I regularly look at the PFTs in patients who are admitted who've had PFTs and show them to the students and interns, and they all look at me like I'm some weird math nut, which is true. I am a weird math nut. And the reason I wanted to do this one, and I'm so glad that we have an expert with us, is I think it's really useful to understand the differences between obstructive and restrictive disease, what causes each, and how we can use this to understand the best approach to the patient. We're not doing this to make money for the pulmonary function lab. We're doing this to help us understand the patient. Drew, do you want to take a shot at it?
I can try. So we have a patient with, by spirometry, it looks like obstructive disease that's non-responsive to albuterol. By lung volumes, it looks like they're also severely restricted as well. And by diffusion, I don't know the norms for what a normal DLCO should be. I think it's above 50%. And if that's the case, then there doesn't appear to be a diffusion related barrier. But again, I'd have to recheck what the norms for a DLCO would be.
So let's, Dr. Bhatt, let's go back to the DLCO first, and then we'll put the story together, and then I'll reveal more about the patient, which I think will emphasize why looking at these PFTs are important for the long-term care of this patient.
Yeah, so the DLCO normal values are again 80% and above is normal. 60 to 80 is considered a mild defect. 40 to 60 or 40 to 59 is moderate, and less than 40 is considered a severe defect. So in this case, I think they fall in the moderate defect category. So this is certainly impaired.
And this could be due to interstitial disease. This could be due to pulmonary hypertension. This could be due to obstruction disease.
Correct.
So Dhruv and Harsha, what test do you want next? And what are you looking for?
I'd want to get a high-res CT with high-res cuts to see if there is any if there's any interstitial lung disease in this patient, because we have a restricted pattern with an impaired diffusion.
So I had the advantage of knowing a little bit more about this patient and having talked to radiologists a lot. The first thing the radiologist would ask me before I did that is, how big is this patient? This patient has a BMI of 43.
Oh, no. Oh, goodness.
It's a
I
real
completely
patient.
forgot that.
I didn't make this up, Drew.
Completely forgot that obesity can also produce a restrictive physiology because of, body fat essentially crushing the rib cage and the lungs down. So
Dr. Bhatt, the patient's had multiple CTs, and I'm going to give you that in a second. But if you had seen the BMI of 43, what would you have thought?
I think I would still interpret the PFT on their own, but BMI certainly has some impact at extremes. there's not a linear relationship between a high BMI and a restrictive picture. But at the extremes, with morbid obesity, for example, BMI greater than 40, there's a higher likelihood that you can have restrictions solely due to a high BMI. But again, we should remember that BMI is a surrogate for obesity, but doesn't really reflect chest wall obesity or abdominal contents necessarily squishing on the lungs. So maybe that's why the relationship is not linear, but certainly BMI greater than 40 should make you consider that as one of the causes for external restriction or extraparenchymal restriction.
He is a large man with a lot of abdominal restriction. Just looking at him, you would guess that. So he's had CTs multiple times over the last 4 years. They consistently show no interstitial changes. One person said that there's some small areas of emphysema. Every one of them says he has a lot of basilar atelectasis. Otherwise, that's really all the information we have. So the question is this obesity-related restrictive disease with mild obstructive disease, or are we underestimating the amount of obstructive disease? And could you explain the DLCO just on that basis? And I'd love to hear what you think, Dr. Bhatt, because this is I think a very routine patient that I see as a general internist.
I think there's quite a few things without looking at the images. I think I'm hoping that when they look for interstitial changes, they did a prone scan so that you can get rid of basal atelectasis, which is quite common. And the larger the body weight, the more basal atelectasis you can get. So certainly most clinical protocols include a prone scan, which I'm presuming has been done, and real interstitial changes have been ruled out. Obesity, as we discussed, can cause a restrictive picture. Obesity can increase it can squish the airways also and cause obstructive lung disease. Not by itself, but if someone has underlying asthma, for example, it can make it worse. There's plenty of literature to suggest that there is more airflow obstruction with people with underlying asthma if they're obese versus not. But I'm not aware of any studies showing obstruction because of airway constriction and squishing, so to speak, just because of obesity. But a restrictive pattern is more compatible. A low DLCO is also compatible with basal atelectasis that can impair oxygen diffusion. It's interesting, not necessarily in the outpatient world, but we see this commonly in the inpatient world, where even a sliver of atelectasis just above the diaphragm can cause significant shunt physiology. It's not really clear how there is a disproportionate amount of hypoxia or oxygen transfer abnormalities, but it's not uncommon. So I think the DLCO changes can potentially be explained by basal atelectasis, so can the restrictive picture. Generally, when you think of obesity and restriction, it's usually an extraparenchymal restriction. So in the absence of atelectasis, a DLCO being low should raise suspicion for something else going on inside the lung. Here, I think if you have significant atelectasis, then maybe that is the only explanation.
Yeah, it was mentioned on 3 different CT scans. They always mentioned it on CT. So my assumption, I have not looked at the CT with the radiologist myself, but they went out of their way to say no interstitial changes multiple times with multiple different CT scans.
One other finding I would look for with these CT scans is to see if they did an expiratory scan as well, which is a common protocol when you're looking for interstitial lung disease. Mm-hmm. Look for interstitial lung disease that are associated with airflow obstruction. For example, sarcoidosis, hypersensitivity pneumonitis, pulmonary Langerhans cholestasis, those kind of ILDs can be associated with air trapping. So it's a common protocol to get those expiratory scans. So that may tell us if there's some air trapping or mosaic pattern, if there's an explanation for the seeming obstruction that we see on the spirometry here.
And that may not have been done. I'll have to go back. The patient carried a diagnosis of COPD, which I think is an incorrect diagnosis in and of itself. And it makes us think different. Now, he does have pulmonary hypertension, which may also have some explanation of his DLCO. I mentioned that he came in volume overloaded, and he has an absolutely normal left ventricle, but he does have pulmonary hypertension and had right-sided edema that he felt better when we relieved his edema with diuresis.
So Dr. Center, one thing I would add is I probably won't rule out COPD, although this is a diagnosis which may be inaccurate. But based on that spirometry, the ratio was borderline. It was 69 and could well have been 70 measured on another day, right? So the ratio can be low, can be artificially high in the presence of obstruction because your FVC goes down and the FEV1 actually improves a little bit with obstruction because your elastic recoil can increase because of the squishing of the lungs. So the ratio can be artificially elevated here and may in reality be much lower than what we're seeing. So I wouldn't really rule it out. And looking at the concave pattern on the flow volume loop, I think it is possible this person still has COPD.
I think he had been a smoker in the past, which I think is why they said COPD. He probably has a little bit of both. I would love for some people to write in the chat the most important thing that they've learned so far and let Dr. Bhatt respond to those, because this is all about thinking through this. And I hope this discussion is going to encourage you to look carefully at the PFTs and try to get better all the time at looking at them. So please do some typing in the chat or unmute yourself and ask a question or make a comment. Drew, we put you on the spot. So what did you feel was the big learning points for you?
I think the biggest one for me was just to be able to sort of review what each specific measurement in the spirometry and of the lung volumes. I think specifically the lung volumes was one that I had not really used much when it came to knowing the specific PFT patterns for obstructive versus restrictive lung diseases on shelf exams or licensure exams. And then for and DLCO specifically was one that I was very confused about and felt like I got a decent explanation for it.
So we got a nice comment from Hassan, who says that learning that TLC alone can diagnose restrictive lung disease. I think that's a really important thing for people to remember, that the total lung capacity is a really useful number. Is that your feeling, Dr. Bhatt?
Yeah, so it's very important to confirm restriction on lung volumes. Spirometry is never diagnostic of restriction. It can suggest restriction, but approximately 50% of patients who have a restrictive pattern on spirometry, if you do a lung volume test, they don't really have true restriction. So it's important to confirm restriction seen on spirometry with lung volumes, but lung volumes are confirmatory.
Harsha, you were very brave, and good luck in your internship. What did you get out of this discussion?
Thank you so much, Dr. Senda. Yeah, I think I agree with what Dhruv said. This was basically reviewing the spirometry, the lung volume, even the DLCO, because that is actually the most confusing part. I really didn't understand how to interpret it, and reviewing kind of the FEV1 to FVC ratio. Also, the basically how to incorporate the patient's history into it was also really helpful.
That's great. Lindsay, you're a brand new attending as a chief resident. How is this going to help you when you make rounds?
I think the number one thing I take away from this, and I try to tell all my teams, well, my one team that I've had as a brand new attending, is just to question the diagnosis of all your patients and go back and look at the primary data and make sure that it's not a diagnosis that was assumed and carried forward for many, many years, and just make sure you always go back to the primary data just to make sure that you're doing the best you can for your patients.
Dr. Bhatt, what do you want us non-pulmonologists to know about PFTs? What do you think are the most important things? Because you've done such a good job of explaining how you look at them and what's really important, and where all the things that are on our readings that are not that important.
I think first step, I think, is to get a spirometry test done. We don't see that commonly in clinical practice, unlike an EKG, for example. Common times, most times when I'm around and I see somebody with suspected lung disease, first, a PFT is never brought up in the discussion, as if it's not very important to the discussion. So that's something that can be improved on, I think. And also, if someone's had a spirometry, that's not commonly commented upon. So I think we should make a good effort to get the spirometers and then read them. A lot of diagnosis, which we assume based on pretest probability, can be completely different once you get to spirometry. For example, COPD is commonly underdiagnosed in the outpatient world. Almost 50% are undiagnosed because they don't get a spirometry. On the inpatient world, 50% are overdiagnosed because they're smokers and came in with dyspnea. They're diagnosed to have COPD and they live with that label for a long time, but when you do spirometry, they may not have airflow obstruction. I think the big message would be to commonly keep interpreting. This one was a very interesting case where the values were very borderline. And just to, I don't want to confuse you too much, but if you were to use a calculator to calculate the lower limit of normal, that 69% ratio, 0.69 ratio could be normal. I don't know. So you'll have to check that and see based on their height and characteristics. And if that was normal, then this entire picture would be compatible with pure restriction, with no mention of obstruction, except for the flow volume loop, which again suggested obstruction. So there are some nuances. So it's not like a blood test where you do a test and say, oh, you have a disease or not, or it's positive or not. There's a lot more nuance to spirometry, which I think you should spend a lot more time on.
So tell me if I have this right. There's no question this patient has significant restrictive disease, and he may or may not have an obstructive component. Is that fair?
Correct. I would agree with that.
And so therefore, if we really wanted to help him, the best way to help this guy, if it was possible, would be to do bariatric surgery, because otherwise we're not going to get him to, I mean, he's oxygen bound and might not be after bariatric surgery. I mean, are there patients with this severe obstruction and obesity that I think that meets criteria for bariatric surgery in 2021?
It does, but I would also look to make sure there aren't other contributing causes, because the DLCO in the mid severity range makes it a little surprising that this person is on oxygen. I don't know how much they're on, but the fact that they're on oxygen is a little surprising.
Right.
But again, I think the basal atelectasis can cause significant oxygen requirements. Yeah, I think to further the discussion, if I saw this spirometry and then before I made treatment decisions, I would probably look for teasing out the cause of shortness of breath, depending on how short of breath they are. There's a lot of clinical gestalt involved. For example, if there is a certain amount of obstruction or restriction, you can guesstimate how short of breath somebody should be, provided they're not very deconditioned. But if you think the dyspnea is out of proportion to what you see on the lung function tests, or if you're not clear about the diagnosis, then you might want to do a comprehensive evaluation with a test called a cardiopulmonary exercise test.
Mm-hmm.
The patients on an exercise bike or a treadmill and measure their oxygen consumption, carbon dioxide reduction, and their anaerobic threshold and things like that to try and tease out what is the primary organ system that's contributing to their shortness of breath.
Great. Well, I hope everybody learned a lot. This is your last chance for questions.
Not really a question, but just to reiterate what I had said at the beginning, and I want to make sure that it's not glossed over, that hopefully within the next couple of years or so, the spirometry norms get reevaluated, and hopefully will be less based on, or have little contribution from the race component, because if we remember the history of how spirometry was initially invented, let's just say that there is a bit of sordid medical racism that was used to develop some of these norms, and you may be underdiagnosing COPD or other lung diseases in your Black patients if you use race-based equations.
Harsha does have one more question for us. Are the flow volume loops supposed to correlate with spirometry and lung volumes?
Yeah, they're supposed to correlate with spirometry. They can be used for two reasons. One, for quality control. So if you look at the flow volume loop, it goes up and then it comes down in the expiratory part. And then they take a deep breath in. And when they take a deep breath in, the end of the curve and the inspiratory part should come back to where it started. If it doesn't, that means they took a small breath to begin with. So all of their values may be a little off. So that is one way to quality control spirometry curves. Second is, if you look at the expiratory loop itself, if it's concave upwards, meaning scooped out like this, that is compatible with an obstructive airway disease. If it's convex upward, that is compatible with the restrictive spirometry, restrictive ventilatory defect. So it doesn't really correlate with lung volumes. It's mainly only for spirometry.
Great. Well, thank you so much for joining us. It's been a real master class, and appreciate you spending the time. There's the number of participants belies how many people are going to watch this, because it goes up on YouTube, and within the first week, over 100 people will watch this and learn from you. So we thank you a lot for being here.
My pleasure. Thank you so much.